and between 2012 to 2014 as the president of the Israeli Society for Neuroscience. So without further ado, I would like to present Professor Esther Shohami, please.
Okay. First, I would like to thank the organizers of this beautiful meeting and doing it in such short period of time. It's really superb job you have done, and I'm really privileged to be here and to share with you about 2 decades of work in parallel with Professor Meshulam on the roles of the endocannabinoids in traumatic brain injury. I'll start with a short description or short overview of traumatic brain injury. What we mean, the kind of trauma that we work with is mechanical, which is defined as external force mechanically injures the brain. And you see some demography of the prevalence of this injury. 2 million suffer, this is from the US statistics, 2 million suffer each year. More than 10% require hospitalization, 5% suffer long-lasting disability, which is a very heavy burden on society and economy, and 3% will die, and the annual cost is $48.3 billion. So it is a major health and financial problem. To date, there is no drug therapy. There is no single pharmaceutical agent that can help traumatic brain injury patients, and the search for such a drug is one of the engines that drive us all in this field. The incidence of having is like we have falls, 28% falls, motor vehicle accidents, sport-related accidents, assaults, military activities, and there are 2 peaks along the lifespan of population. There are adolescents, which are mostly men, which are involved in sport activity, in extreme sports, and in more in combat. And the elderly, falls becomes a big issue. So let me first overview a few of the pathology and what do we mean when we are talking about traumatic brain injury. We know that there is a primary insult which starts a complex of events, and many mechanisms are activated after the initial injury. For instance, the primary insults result in rupture. It is mechanical force which really ruptures the membranes, and it leads to damage of neurons, glia, vascular components. Every single cell type in the brain is affected. The disturbances are not only mechanical, they initiate metabolic stress, destructive release of all kinds of mediators. Many different molecules which are stored in the cells are released, like glutamate, reactive oxygen species, inflammatory mediators, and these are all part of the injured mechanism that leads to the harmful consequence that we see. But also, in parallel, we now know that there are some reparative processes that the brain tries to protect itself. The trauma-induced brain swelling, there is accumulation of water, and there is intracranial pressure within the skull. There is pressure, which is part of the consequences of the trauma and is one of the leading cause of disability and death after trauma. And also, part of the damage is mediated via constriction of the blood vessels. Local cerebral blood flow can be reduced due to constriction of the blood vessels. Less blood is coming to the area of the trauma, and the lesion volume is expanding due to ischemic event. So these are some of the pathology that we'll touch upon in my talk. That's why I wanted to have some, to be on the same page when I show you later the effect of the cannabinoids. So this is a scheme that Yossi already showed you in the morning, and as you can see from the primary injury to the secondary brain injury, there are lots of pathways which are involved, and some of them will be mentioned in the talk. We'll revisit this slide it's the end of the talk, and then we'll see where the endocannabinoids can play a role and help us to decrease the secondary damage. So if we look on the temporal profile of the changes, because what you showed up to now is just a bunch of events that happen, but it doesn't say when things. This is a very sequential pathology. First, in the first minute, we have calcium influx. Calcium influx is one of the earliest events that we see after trauma, and it's important because I'll get back to it in a minute. Glutamate is released, and it's toxic. Glutamate is a very important neurotransmitter, but when the levels of glutamate are too high, it becomes excitotoxic. It really kills the cells. And of course, there's imbalance of other ions, and this happens within minutes. Later, within hours, edema, water is accumulating, inflammation is developed, blood-brain barrier is disrupted, and the brain is most exposed to toxins from the blood, and cells are starting to die. Within days and even longer, weeks, months, we see that the intracranial pressure is still maybe over there, hypoxia, secondary ischemia, and apoptosis. So at the same time that from hours to days, in addition, we start to see repair mechanisms which are trying to help the brain to recover. So these are the window of opportunity, as we call it, to come with a drug and help to increase the repair and remodeling process, because within minutes it's too short and there is no way that we can help the patient within minutes after trauma. Maybe one day it will be possible in the ambulance or in the rescue team to treat, but at the moment there are no therapy and nothing can be done within the first minutes. So to summarize this part, the introduction, the final outcome is an outcome of two competing processes, detrimental processes and healing. And what we are trying to do with the endocannabinoids to see whether we can energize and activate the healing processes which are mediated by the endocannabinoid system, as I will show you in my talk today. So the endocannabinoids, I don't think that after this morning we still have to introduce them. We heard so much from Professor Meshulam, later from Yossi. So this is the family, and it's now an extended family. We have many more, but this is the basic. And 2-AG was the first candidate that we were looking at. Just a reminder, the two types of receptor, as Yossi showed, there's CB1 and CB2. And CB1 is mainly found in the brain, and CB2 mainly found in the periphery. However, we can still find CB2 in the brain after trauma, as you will see later. And the question was, okay, let's start and looking into the CB1 system, which, as you heard, is comprised of enzymes which synthesize these molecules, enzymes which degrade them, receptor which mediate the effect, and of course the key players are the molecules themselves, the endocannabinoids themselves. Well, as we heard this morning, nearly every organ has this endocannabinoid system. Everyone can pick his favorite organ, starting from the gut, kidney, pancreas, bone. You can go the whole circle. This is my favorite organ. I work on the brain. And among you see there is a whole list of disease like Parkinson, Huntington, Alzheimer, ALS, MS, traumatic brain injury, which is my favorite disease in this context, schizophrenia, and depression. So there's a lot of pathologies which involve the endocannabinoid system, and I narrow myself to the traumatic brain injury in this context. Just go back to something that Yossi alluded to before, and give you an example and try to explain what does it mean to modulate the effect of a neuron. Here we have a synapse, presynaptic. Do I have a, oops. A synapse, the presynaptic neuron, you see these little circles are a neurotransmitter which is pre-packed in a vesicle and waits for a signal to be released and to activate the postsynaptic neuron. So if you see the yellow lightning coming from the presynaptic neurons, it causes a raise of calcium, release of mediators which activate the postsynaptic, and the signal goes on and on. However, if there is overactivation, if some reason there is too much of glutamate, in this case, too much of activation of this postsynaptic, we have high levels of calcium, which occurs within minutes, as I said. High level of calcium triggers the synthesis and release of 2-AG and anandamide from the membrane of the postsynaptic neurons. They go backwards, the COC said retrograde activation of the CB1 receptor, which can be found on the presynaptic neuron. Activation of this CB1 inhibits the release of the transmitter. So here you have the whole loop, which explains what do we mean by modulating the activity of the neuronal activity. And this is achieved by THC, anandamide, 2-AG. Any compound that will bind to the CB1 will be modulating this effect. Okay, now to the main talk, cannabinoids and traumatic brain injury. What was the first question that we asked? Now, why did we ask it? I work in the School of Pharmacy, few floors above the lab of Prof E Shohami, and for quite a long time he came by and said, well, it's time to check cannabinoids in the brain. What happens in trauma? And finally I said, okay, you are so persistent and you're so enthusiastic about your field of cannabis. By that time I wasn't there. I said, okay, let's go and check for it. And we recruited a very talented PhD student who was the driving force of this work. First thing we asked, what happens in the brain to the levels of 2-AG? Does it remain constant? Does it go up or down? And this, Rafi, I think, showed this early in the morning. We see that there is an increase within 1 hour, peaks 4 hours after injury. There is a major release of 2-AG. And the question was, okay, there is a lot of 2-AG. What does it do? Is it good? Is it bad? Or is it just a standby there, does nothing? So how do we address such a question? Rafi has synthesized in his lab 2-AG. It's not the molecule that we extracted from the brain, but it's synthetic 2-AG prepared in Rafi's lab. And we said, okay, this will be the drug that we'll now be using. We inject it to the mice, a model that we have developed and worked with for a long time. And we'll see what happens to the functional, the first question, what happens to the functional recovery of the mice after trauma? And you'll see several times the term delta NSS, which means the change in the neurological severity score. It reflects the recovery. I will not elaborate, of course, on the methods, but this is an extent of recovery. In yellow, you see the extent, the spontaneous recovery, which is quite low. But after treatment with 2-AG, we got significant, highly significant better recovery, and 5 milligrams per kilo was chosen. As you see, it is kind of bell-shaped dose response. We chose the 5 milligram for a set of experiments that we conducted since then. And a summary. Here is a summary of what we found about the exogenous 2-AG. It reduces the motor deficits, as you see here. It reduces the edema, the accumulation of water. It's the blood-brain barrier, which is disrupted after trauma, was preserved. Hippocampal cell loss, we could count the number of cells which are dying. It was less cell death, less production of cytokines, namely anti-inflammatory. This was very important, as I'll come back to it. Less cytokines production means less inflammation. It's an anti-inflammatory drug. And finally, we looked at the vasoconstriction, which is induced by endothelin, a most potent vasoconstrictor, and it is counteracted by 2-AG. So here I'll show you just some examples. It's not just a list of what we see, but you'll see the actual data. Also, Rafi showed this in the morning. We see here the lesion volume is the white area that you see on the side, because this dye that stain live cells. And if cells are dying, we don't get the dye in, and we get a white area. So here we have in control about 10% of the cortex is infarcted, and after treatment, there is about 50% less infarct volume. Here we counted the loss of neurons in the hippocampus, and the upper part, in the right side, you see the sham, normal, uninjured animal. Below, you see how it looks after trauma. There is a chaos of the cells. They are disintegrated and die. And in the middle is after 2-AG, and we quantified it, and you can see that significant higher level of live cells can be found in the hippocampus after treatment with 2-AG. At that time, we had a collaborator from Thessaloniki in Greece, and they were very interested in our results because they worked on an animal model for multiple sclerosis, which is an autoimmune disease, but with a very strong component of inflammation. And their model of EAE, they had two models, one of acute and one of chronic, and I will not go into the details, but they treated the animals with 2-AG after induction of the disease. And what we see here is that both up and down, the upper and lower panels, we can see that the course of the disease was delayed, and also the extent of damage. This is also clinical score. The extent of damage was lower, and when they looked, they stained the spinal cord axonal pathology, and they found, I'll just draw your attention to this finding. They counted the percent of axonal loss in non-treated and in treated, and they found that high axonal loss we get in 10% of the animals and only 2% in those who were treated with 2-AG. So it's not only that the inflammation is down, or because of the inflammation is down, we have preservation of the axonal, and the significantly less axonal pathology is found in this model of MS. In the morning, there was a question about autoimmune disease, so maybe this can be a hint towards the effect of 2-AG or endocannabinoids is anti-inflammatory in those diseases which inflammation is mediated of the disease. Now, what about so far, we use 2-AG, and 2-AG acts on both CB1 and CB2. We were puzzled by the question whether CB2 can be found in the brain or not, but we said, nevertheless, since after trauma there are reports showing that 2-AG, that CB2 receptor is found in the brain, let's see what happens after trauma, because part of the inflammatory response is mediated by the CB2 receptor. So what we see here is that after trauma or after ischemia, there is activation of the inflammatory response, which is completely or very effectively inhibited by activation of the CB2 receptor. So the CB2 activation inhibits the inflammatory effect, and we thought, so maybe it will be also helpful in trauma. Now, the CB2 is not, we don't have any endogenous endocannabinoid which is selective to the CB2. Neither in the plant, none of the compounds was selective to the CB2. So here comes Prof E Shohami with his ideas to synthesize so many molecules, and AGU-210 is the molecule that his PhD student Lital Magid synthesized and was found to be highly selective to the CB2 receptor. And we asked the question, does it affect recovery after trauma? And what we see here, this is the recovery, the delta, again, the extent of recovery after trauma. In the middle, I don't have a point. Is it a pointer? Never mind. In the second line below it is the spontaneous recovery. And here we have another study with the same drug. And the difference between these two panels is that we used different types of CB2 antagonists. The question was, can we block the effect of the drugs with antagonists? If we block the receptor CB2, we will block the effect. And if we block the effect, we would expect to get back to the same level as the spontaneous recovery. Okay, we have spontaneous recovery, we improve it with the drug, we block the drug, and we go back to the spontaneous recovery. But see what we got. Both types of receptors brought the level of recovery way below the spontaneous one, let alone it completely abolished the effect of the drug. And in both types of receptors, the effect of the inhibitors were even much more on the, it completely blocked the effect of the drug and abolished the spontaneous recovery, which means it tells us a lot. This slide tells us really a lot because it says that even in the spontaneous recovery, CB2 receptor is playing a role. Because if we blocked CB2, even the spontaneous recovery became much less. So let's leave the classical endocannabinoids now and go to start looking into the new family which was discovered. Again, the first discovery was done by Rafi, 2-arachidinoylserine, or 2-RS. It's a family, we call them FAAA, fatty acid amino acid, and they have very similar structure to anandamide, to the classical endocannabinoid, but they don't bind to the receptors. And this is quite puzzling, because if they are so similar chemically, they don't bind. Do they have any effect at all? Maybe they are just there, but they don't do anything. So we decided to have a close look into the 2-RS. It was first published in 2006 by another student of Rafi's. And we, together with Rafi, had another student, Ayelet, which looked into an effect of RS on traumatic brain injury in the same type of model and the same parameters that we looked at with the 2AG. So first we see that there is a very nice delta NSS. Recovery of the motor function is very nice and long-lasting. Here we have up to 28 days. We followed it even up to months, and it preserved the recovery, which we see in the beginning is really sustained for a long period of time. Lesion volume is significantly less, but the effect of RS, all these effects were abolished by CB antagonists. How come? They don't bind, but they still affect, we can block the effect by the antagonist, which means there must be some kind of connection between the whatever entity the RS binds to and the CB1 or CB2 receptors. So we thought if there is an effect, maybe it's not found via the receptor, but we should look into the cells, into the signaling mechanism. What do I mean by signaling mechanism? If we have the cell membrane, there are receptors on which look at the outer, at the extracellular part of the membrane. A ligand is bound to the receptor and activates a pathway which finally yield the final outcome or the final response of the cell. So we decided to look into this pathway, which is activated, the phosphorylation of AKT, BCL-X long, and anti-apoptotic genes. So this is a known pathway which is part of a protective pathway. Survival signaling are mediated via this pathway, and we decided to look whether RS affect these pathways. So what Ayelet looked at is the phosphorylation of phospho-AKT. As you can see, significant higher levels of phospho-AKT. No, it was 12, 15 minutes. Okay, high levels of phospho-AKT, high levels of BCL-X long, and lower level of the caspase activity, which is indeed a harmful enzyme, which leads to cell death. So we can conclude from this part that, okay, I'm here. So what we can conclude that the RS acts via signaling, which is probably somehow connected to this CB receptor, but not directly. So we thought maybe there is another pathway that can be activated by the RS, and this is based on literature showing that cannabinoids affect the neural progenitor cells. So if they show me that I have a few minutes, so I'll rush. The idea was to isolate neural progenitor cells. These are stem cells which are not, they are in their immature form, and they are found in the brain as kind of, and not activated maybe through the whole lifespan until they're required to help the brain to recover itself. So what Ayala did, she isolated these neuroprogenitor cells and exposed them to increased levels of RS, and we found that there is significant high increase in the proliferation of these cells when they are exposed to AG. So again, this effect was completely blocked by the antagonist. What we did find of the RS is doing to the neuroprecursor cells, they induce the expression or increase the expression of CB1. So exposure to RS may induce the levels of CB1, and that's how the RS might work. We are not sure yet if this is the final mechanism, but this is a proposal, and I will rush to my next slide because I was told that there is not enough time. Okay, so another aspect of the cannabinoid activity was also mentioned in Rafi's talk, and is the effect on the circulation. As I mentioned before, after trauma, blood vessels are constricted because they are exposed to high levels of endothelin, which is released after trauma. So in this study, which I did when I was at the NIH in sabbatical with Maria Spartz, we worked on human brain endothelial cells, isolated human brain endothelial cells. When they are exposed to endothelin, within 30 seconds, very low level of endothelin is enough to cause vasoconstriction. So here you see the bar, the line, the 100% is the maximal effect that we got when exposure to endothelin. And then we started adding 2AG to the culture, and you see a beautiful dose response effect. The higher the level of 2AG, the less constriction we get, or this is a model, so the less level of calcium accumulation. This is the endpoint of the study. Calcium accumulation is minimized by adding the 2AG, and this effect is reversed by a CB1 antagonist. So again, there is a CB1 receptors on the microvasculature, which within minutes or seconds can respond to be vasoconstricted or vasodilated. The effect of the vasodilation is mediated via 2AG, and later we tried also the effect of RS. And what you see here is in red, what you see is the staining of the cytoskeleton. This is a dye that marks the cytoskeleton, and when we see red, means that the cytoskeleton is rearranged so that the vessel is constricted. So you see the level of the cytoskeleton arrangement in untreated, nothing. RS itself, not much, nothing actually. Endothelin, there is high vasoconstriction, this is the red, and after addition of RS, the red is gone. It means that there is vasodilation and the structure of the organization of the microvasculature is blocked, and we have vasodilation. And I won't go further. And here is the final study, which so nicely, with a cranial window in vivo, shows the effect of the endocannabinoids on the circulation, vascular circulation. This is a open skull. There is a window through which, with a microscope, one can see. And I cannot point to the point, so I'll go straight to the analysis. In blue, you see the change from baseline of the diameter of the blood vessels, and in blue is the vasoconstriction because it goes down, the vasculature becomes constricted. The diameter is 20% lower when we add endothelin. When we add LEA, L-E-A is the cannabinoid, linoleic, ethanol-amine, it goes up. There is vasorelaxation. And when we give them both, the effect of the cannabinoid on the ET is such that the vasoconstriction is significantly less, and thus we can protect the brain from the ischemia. So, if we summarize this part, because this is the really most recent studies, RS enhances the expression of CB1 and CB2 on the vasculature, and it abolishes the ET-stimulated calcium mobilization, and this is part of the modulation of the blood flow and regulation of the microcirculation. So if we go back to this slide, let us focus on where cannabinoids are protective. Here, they inhibit the glutamate release. You remember the loop that I started with? Glutamate release is toxic. They inhibit the neuroinflammation. I didn't show you exactly, but it inhibits the cytokine release. It inhibits the ischemic reperfusion syndrome. It inhibits the vasoconstriction of the blood circulation. It inhibits radical oxygen species from, I didn't show you, but we also have data to support this. So in a whole, there is no, it is not surprising that they are a multi-potent drug to inhibit the secondary damage. So both CB1 and CB2 receptors are involved in the post-traumatic neuroprotection, cerebral vasodilatation, and neuroregeneration. Non-CB1, CB2 mediated pathways, which are used by the FAAs, they also exert neuroprotection, and our results strongly support members of this extended cannabinoid family as novel therapeutic agents for traumatic brain injury. And I would like to thank my colleagues and students that are part of this project. Of course, Prof E Shohami from, you don't have to introduce him, Maria Spatz from the NIH. What happened?
Bueno, ¿preguntas? ¿Alguien tiene una pregunta? Sí.
Muchas gracias, doctora, por su exposición, y quería saber si se espera poder usarlo en humanos para prevenir el daño ante una injuria cerebral.
Well, the question is, can we treat humans to prevent, yeah. Of course, as we heard this morning, the translation from the basic to the clinic takes time, but we do, since CBD is involved already in clinical use, and to use these molecules as they are, their lifetime is quite short. They might be cleaved in the brain, they will be metabolized. So we have to synthesize some analogs. And if synthesize analog, you have to go through the basic research, and then you have to go and show if toxicity, I mean, all the 3 phases of clinical trial. But I do believe that this principle is very strong, and it should be, some manipulation should be found, and it can treat patients. With CBD is already approved in several indications. I didn't show you any CBD or THC. What I focused on is the endocannabinoids, but we do have results with the plant-derived compounds, and they act quite similar. So it might be easier to go this way. But I do believe that this is a very potent therapy that we can provide.
¿Otras preguntas?
Sí, buenas tardes. Primero le quería preguntar, ¿cuánto tiempo después de la situación traumática habría que aplicar este tratamiento, y si hay una dosificación por kilo? Gracias.
Oh, this is an excellent question, because as I showed, there is a very dynamic changes, and the question is when we can intervene. With RS, we showed that even if we intervene days later, we can get some benefit. Not as good as when we intervene within 1 or 2 hours. So it's a matter of course, if it should go into clinic, we have to do very careful dynamic or pharmacokinetic of the treatment, find the right therapeutic window. The best is the sooner the better. But as I said, we showed that since part of the mechanism like neurogenesis and vasoconstriction are also mediated, maybe we can get part of the benefit even if we try a week later. This is what we tried. But it has to be done very sequential and to find the best window. Okay, thank you very much.